Mr. John Kanyi Maina, who is a board-certified clinical chaplain working at KNH. He has a deep commitment to provide compassionate spiritual care. He supports patients, families, and staff through various challenges and crises within the hospital. And he also serves as a member of the Hospital Ethics Committee, where he contributes his expertise in addressing ethical issues in patient care. And just in case you didn't know, professional chaplains actually lead and participate in healthcare ethics programs in various ways. They assist patients and families in decision making. They clarify values within patients, family members, staff, and the organization. And they are very instrumental when it comes to the institutional review board. So when you hear a chaplain, don't just think about prayers. Over to you, Reverend John, to introduce the speaker. Thank you.
Thank you so much, Dr. Nafula. I hope I'm audible.
Yes, you are.
Thank you so much. I appreciate. I want to invite you, all of you who are joined already and continue joining. We all agree this is a very significant dimension of healthcare. And so we have lined up a great facilitator who is going to be taking us through the roles and functions of a hospital ethics committee. Now that Daktari has already established my credentials, I don't want to go over that again. I think we just dive on to the business of the day. And so our facilitator today, Professor John Wero, is an associate professor at the Aga Khan University Hospital, and is also the chair of the Hospital Ethics Committee in Aga Khan University Hospital. He's also the vice chair of the Global Aga Khan Ethics Review Board, that is also course-led for both the undergraduate and postgraduate bioethics courses at Aga Khan Hospital. He is an adjunct faculty member with Mount Kenya University, the AMREF International University, and the CBEC Kemri Bioethics Training Initiative project. He's a peer reviewer with multiple journals and has written peer-reviewed articles in both chapters. He is the chairperson of the Kenya Hospices and Palliative Care Association, otherwise known as KEPSA, and the head of palliative care services at Aga Khan University. And so I want to bring in Professor. You can take from there as we run to the presentation. Then at the tail end, we'll have questions and answers as we go on with the program. Karibu, Professor.
Thank you, John, for that kind introduction. I hope I'm clear, audible. You can hear me?
Yes, you are.
Okay, so we're going to discuss in a few minutes about the roles and functions of our Hospital Ethics Committee. And I want today to be a discussion, and the outline will be, we'll have some introduction. We'll see how does the Hospital Ethics Committee approach its activities, and indulge ourselves in the types of cases handled by the Hospital Ethics Committee, and spend a lot of time on the Q&A and our discussion. So we might ask ourselves, what is clinical ethics? Because if you look at the framework of ethical discourse in a healthcare facility, there are three arms. One of the arms is clinical ethics, but the other two, the second one is research ethics, and the third one will be governance ethics structures. But for the discussion today, we're talking about clinical ethics. So the Hospital Ethics Committee can variously be also called the Clinical Ethics Committee. And clinical ethics essentially mean that it's a practical discipline providing a structured approach in assisting healthcare providers to identify, analyze, and solve ethical issues that we do face in clinical practice. So it's clinical issues, but notice that it's a practical discipline. It's not theoretical. So you have to be on it. You have to essentially deal with cases that affect clinical practice and provision of healthcare to patients and families. And we realize that the socio-cultural contexts are changing a lot with the attitude of the public towards the clinical professions. Think of any clinical profession, be it medicine, be it the nursing profession, be it the clinical officer's profession, be it towards the lab and even the investigation arms of the healthcare providing professions. The attitude is changing with the patients and the family members and the public having more choices. And this actually is changing how we do our clinical ethics approaches. So at the end of the day, what is right and what is wrong must be decided. And the context do influence how we go about it. But remember, when we talk about socio-cultural context, we are not only talking about traditions. We are talking about how communities and how societies today are dynamic and how they view their rights, their practices, and their beliefs toward the various issues that they do face day in, day out. And we are all cultured in different ways. For example, how would you approach a cultural community that is LGBTQI and you have issues that are facing them? How would you approach a cultural community that is towards saying that this is not how we believe practices should be done? So it's important for us to know that with these two bullets and adding the fact that technology has come in very handy. Talk about technology in the world, talk about technology in the critical care areas, intubation, ventilators, talk about technology in the AI world. The AI is with us in the clinical practice. How do we deal with this? So the challenges are becoming more and more significant when it comes to clinical ethics. As we proceed, it's very important for us to say, what would be a right composition of a hospital ethics committee? But there's no prescription or a standardized way of looking at the composition per se, because it will vary in size and has diverse memberships, which represent a variety of disciplinary and community perspectives. You realize that your committee at KNH has got a pastoral leader. But because it's a clinical ethics committee, clinicians are a must for this to sound clinical. But they are not the only people. So that multidisciplinary team approach is very, very critical. You also realize that you'll have representatives of the major medical department in the hospital. For example, the challenges you face in end-of-life care, in the beginning of life, in the critical care areas, and in the nursing areas, detail that a hospital ethics committee should have representatives from those areas. Of course, we have a lot of challenges in understanding spirituality and how it significantly influence healthcare provision in the clinical areas, and they must be represented. And the other supportive services, such as social work and counseling and everybody else, and now the extended hospital ethics committee are also having representatives from the pharmacy departments, because you realize that there's a lot of ethical challenges when it comes to dispensing medications to patients. Think about substitution of a prescription. Think about the education that goes to patients. Think about availability of the drug. So this composition is not prescribed, but at the end of it all, we must, when we call it a committee, it has several members. And it is not an ad hoc committee, it's a standing committee of the hospital. So we cannot just call it when need arises. It's a 24/7 committee because the hospital is also 24/7. In some areas, you realize that some hospitals will have a bioethicist on call. So they don't have a committee, they have a bioethicist. But in our setting, for the sake of discussion today, we talk about the committee. Some committees will have hospital administration representatives and also community reps. Now, the patients come from the community. The adage today and the rule today is what you do for me without me is actually against me. So any hospital ethics committee, what it's sold, have got community representatives among its membership. And of course, different members will bring in expertise from the different areas. And what are the roles now of the hospital ethics committee? They are triad roles. And one of them is a case consultation. And in this case, they do provide consultative services dealing with ethical issues or ethical dilemmas faced in healthcare provision. And ethical issues can cause moral distress. Ethical issues can become ethical dilemmas. If there are two ways of looking at them, or two ways of how we can proceed with the case at hand. And at the end of it all, you realize that most of the litigations that are coming in emanate from ethical issues or ethical dilemmas when you're dealing with patients or family members and anything around the patient. And we'll see how they can be outlined. And finally, it is very important for us to look at a case consultation as a way in the hospital to minimize the moral load and the moral distress on the healthcare providers. So when they are not sure on the way to proceed, the hospital ethics committee comes in so that the load is shared across, and therefore the moral distress is reduced on the healthcare providers. Here we are talking about any person that is engaged in the care of the patient, from the senior consultant all the way to the porters. So the nurses are there, the clinical officers are there, the people who come to draw blood are there, and the people who actually take care of the patient in the ward. So that's one critical role of hospital ethics committee. And as such, you cannot talk of a hospital ethics committee if it's not doing point number one or bullet number one. Then of course it's charged with education so that it does facilitate education for its own members, its healthcare professionals or providers, the patient, the families, and the community that you serve as a hospital ethics committee. And eventually, any policy, any procedure, any guideline that feeds into activities that do detailed provision of care to the patient require hospital ethics committee, whether it is being reviewed, the policy guideline, SOP, or protocol is being reviewed, whether it is being developed, whether it is being evaluated, these need to go to the hospital ethics committee. The reason being is a clinical ethics committee. Anything that will affect the provision or might affect the provision of care to the patient required to go through the hospital ethics committee. So think of any policy in your institution, whether it is a blood transfusion policy, whether it's a prescription policy, whether it is a guideline towards how you take or you feed into informed consent, or anything that requires an input of the hospital ethics committee, because it will influence how provision of care is done to the patient. But for the sake of today's discussion, and I hope we'll get more time, we're going to pay attention to bullet number one. Case consultation, we said, is a key activity of the hospital ethics committee. So we've talked about ethical issues and ethical dilemmas. So what is a dilemma? Sometimes clinicians do face a dilemma because more a time, the provider and the patient or the family or the person who is representing the patient, they have differing opinions on the appropriate care for the patient. So that the healthcare professional is using the principle of beneficence, doing good, well-being of the patient. But then the patient using the principle and the power of respect for autonomy is of a different opinion. So this is the commonest ethical dilemma that we do face in providing care to our patients. However, if you look at the 4 principles of medical practice, starting with respect for autonomy, non-maleficence, that is doing no harm, first do no harm, beneficence, that is the well-being of the patient, doing for the benefit of the patient, and eventually justice, especially distributive justice, access, equity, affordability, then you realize they are just more than respect for autonomy and beneficence. But in the clinical arena, we do face this. However, ethical dilemma usually comes from having some ethical issues. So I think an ethical issue will be something like, was the informed consent fully informed? Was it fully informed? Did the patient fully understand? That's an ethical issue. And for us to talk about ethical issues, ethical dilemma, clinical ethics, away from the principles of medical practice, which are four and have to be contextualized, it's very important for us to talk about 4 principles that guide patient care. Wherever you sit and whoever you are, providing whatever level of clinical care or care to a patient or a family. One is that the patient shall be treated as a whole, autonomous, irreplaceable, unique, worthy person. Now, irrespective of where the patient comes from, what they believe, their ethos, their color, their gender, sexual orientation, religious beliefs, if they have any, they have this right, and it's a principle that we all have. So that from this one single given principle, you can see where ethical issues can come in. The other one is the patient's safety, health, welfare should be protected. But more importantly, should not be subordinated to organizational, staff, educational, research interest, or to any other aid, so that the patient is not treated as a means to an aid for the institution, for the clinicians, for their families. The patient is an aid on themselves. And looking at that bullet, you realize that the policies and the guidelines that we have and the organizational ethics and frameworks might sometimes challenge this. And we are called upon to take a step back and see that a patient is whole, irreplaceable, and not subordinated to whatever the staff, organization, educational research activities do affect. And you look at most of the institutions with research, with the clinical areas, then there's a challenge there when a patient become a participant and the clinician become a researcher. That's the second principle. So do you see any ethical issue in this? Very many. So the other 2 principles are privacy of the patient and confidentiality of every case, and records shall be maintained. And when you talk about privacy and confidentiality, they are key terms that we do utilize in provision of healthcare, and they come to us as Hospital Ethics Committee having been challenged. And the patient has got a right to privacy, whether informational, body integrity, associational, and the belief that they have. And of course, patients and responsible family should be informed at all stages of care about personnel responsible for their care, the plans we have for treatment, activities for the patient, facilities and services available to the patient, the options and alternatives, and what are their responsibilities. Remember, if you look at clinicians, they have obligations, but obligations have to be balanced against rights. The same as patients and family members, they have rights, yes, to be treated, to be cared for privacy and confidentiality, to be maintained without being breached. But they also have an obligation to respect, to treat well the providers of care to them. So with those 4 principles then, let's see, how does the Hospital Ethics Committee approach a case? Now, they do understand and question the fact. Please understand where the Hospital Ethics Committee is coming from. Whatever information you give them, they have to go back and see what is the question you're asking them and what they are studying. And then they will, of course, identify the different stakeholders. Stakeholders in patient care are extremely important. And stakeholders are not only the family members, they are people that the patient has identified as the people who can act on their behalf, but also every other person providing care to this patient, from nurses to those who are doing investigation, those who are doing prescription, those who are also navigating the patient within the institution. Those are important stakeholders. And then, of course, they'll discuss the treatment options, if any. They do document, record, and report the recommendation. Anything that was not documented, recorded, and reported in the various ways that the Hospital Ethics Committee does was not, and I do repeat, it was not actually done. The Hospital Ethics Committee will also approach and evaluate the outcomes that they will have done. So with this now, if you look at the Hospital Ethics Committee with these 5 bullets, then it has a duty to do this, an obligation to do this, but they also have a right to an enabling environment. An enabling environment comes from us as clinicians, come from the leadership of the institution, come from the policies and guidelines that we develop, come also from the constitution and the law that guide healthcare provision. How do we access Hospital Ethics Committee? I would recommend that we do answer all these questions, child, what, when, where, how, why, what, who. And they will do this by a consult. And remember, Hospital Ethics Committee is 24/7. So if you have a team, it will be on call 24/7. If it's on in the committee, 24/7. So we cannot say we are not calling you at 5 a.m. or you cannot get a Hospital Ethics Committee. Let's not give reasons of not calling the Hospital Ethics Committee. Ethical issues, ethical dilemmas do arise 24/7, 365, 7 out of 7. As long as the institution survives. So once you set up a Hospital Ethics Committee, it has to outlive any of us, any of the patients we're taking care of today, any of the policies and guidelines that we're using today. That's why it is very important that it continues evolving. So a consult will be initiated by medical staff or hospital staff, hospital admin, and most importantly, the patient, patient's guardian, member of the patient family, and other stakeholders in the patient's care. When you start, you have the first 3. As you continue, the patient becomes very good and they consult you a lot. And of course, there should be modalities of accessing the Hospital Ethics Committee, whether it's a phone call, email for consultation. And of course, even using these modalities, confidentiality must be maintained so that a phone must be used for the activities that's supposed to be. So let's not give reason that we are not accessing Hospital Ethics Committee because it is at night, because it is Christmas and we are going to have to break, or it is Easter, we are going to break Easter eggs. No. And what is the process? Of course, the consulting person will call the hospital ethics on call. So the hospital ethics does not come to the clinical area until and unless they are consulted. Until and unless. So we usually hear, where was the Hospital Ethics Committee? And we ask, why we consulted? On call, of course, we inform colleagues. We'll review the medical record. We'll identify the stakeholders. The primary doctor has to be invited and informed, and they decide on the way forward. Of note from this slide is the fact that you have to review the medical record. What I tell you as a Hospital Ethics Committee does not give you full information. Be very careful when we only get the clinical data minus the patient's context, beliefs, and where they are coming from. So after the process, then I wanted us to indulge more now, moving on from the type of cases that we do face. And the cases we face can be outlined this way. So I decided, can we summarize the cases we do come to us as a Hospital Ethics Committee? And one will be end-of-life care issues. And this is the way we outline them. But I also wanted to show you the number of cases that we do face based on this classification. So the next slide now outlines the numbers. And one of them is, it's very common for us to almost every other week to have issues about end-of-life care. And this will be many. One question is futility of care. We feel that this care is futile, but the patient feels that they should be receiving this care. The family members feel that they should be, their patients or their family members should be receiving this care, but the healthcare providers feel that it's futile. The concept of futility of care has been researched on, has been documented. Literature is very rich on this futility of care. Futility of care means that we believe that the patient won't benefit from this care that we should be provided. A word of caution is that futility of care must be taken within the context, because what might be futile to the medical practitioners might not be futile socially. And we get these cases coming to us that my daughter, my son who is abroad, I've not met them for the last 10 years. I would want to be kept alive as much as possible for them to come because they are coming next week. And then you ask the patient, if your situation deteriorated, can we also intubate you? And they say yes. If they only see me, then that is what I would wish for. I don't know what this group would look at that case, but let's be careful that what might be medically futile is not always socially futile. The concepts of advance directives, did the patient have any expressed prevalences of the level and the place of care and how they wanted to be treated when they could not make a decision? And advance directives are coming in very strongly to tell us the preferences of this patient when they were able to make a decision. Now they cannot make a decision. They are very, very important. And I know we are all working towards having this document. What we need to do now is we need to petition our leaders for this advanced directive documentation to be domiciled within the laws. But if you read aloud the legal statutes that guide practice of medical practice, because advanced directives is part and parcel of quality, full care, then we always argue and discuss the fact that advanced directive discussions are very, very important. And of course, we have the issue of do not resuscitate. Do not resuscitate, do not attempt resuscitation. And this is a big ethical issue that you face and we face, especially where you have technological advancement. When you have patients who are going through intubation, how do you approach that if the patient required resuscitation, for example, where you have advanced technology? How do you deal with that? And this is one of the common cases that we do face, and we are called upon to see, for example, some patients come in with the advanced directive. Now they are not able to make a decision, and advanced directive is being petitioned by the family members. That's a case you face as a hospital ethics summit. So we need to call them. Let's not distress ourselves where a question of advanced directive or the applicability of do not resuscitate comes in. You have the resource called the hospital ethics committee. Level of care and place of care, very, very important. For example, level of care, patients say, do not take me to critical care. I wouldn't want to receive any treatment geared towards sustaining my life in the hospital, and the place of care I wish for should be home. I should be taken care of at home. But sometimes place of care, now we have a flip that people want to be in the hospital some of the times. And of course, type of care is very, very important. We get cases where a patient is demanding a type of care that essentially they do not meet the criteria to receive that care. For example, a patient comes and demands to have a cesarean section. They don't meet the criteria for a cesarean section, but they're saying it's our right to make a decision for that. So the clinician or the doctor says, no, according to our guidelines, according to the criteria, you don't meet the standards of having a cesarean section for you, and what we need to do is spontaneous vaginal delivery. So the physician here or the doctor here, gynecologist, is using the principle of justice, the principle of resources, utilization of resources, and the issue of using criteria that are laid down. But the patient might be saying, it is my body, I need to make a decision. So that is an ethical dilemma that you face. And of course, there are so many other issues around that. Something else that is coming in strongly, decision-making process. Who is the next of kin? Anytime you have such a question, please run to the hospital ethics committee, because patients can have very many next of kins. And we need to define this term, next of kin. Who is a kin, for example? It's a family member, someone related to the patient. But for the sake of healthcare provision, the next of kin who is documented is someone who is supposed to receive information about the patient. It's not about the patient estate, it's not about the patient's goats and cows and pieces of land. So we have to define the term and the utilization of the term next of kin. So a patient can have 6 wives, you can have a side chick or a partner or anybody. Now we are having to detail the fact that patient come in with so many people. So who is the next of kin? And our duty is to ask the patient who can act on your behalf, who should receive information on your behalf. And if the patient has got advanced directives, please, the Hospital Ethics Committee will advise you that advanced directives with the patient who is recognized, the person recognized by the patient as the person who holds the medical power of attorney supersedes everybody else. In a hospital setting, they might not out there when you come to pieces of land and number of goats and all that. So who makes a decision? Is it the first wife or the second wife or the firstborn son? And what influence does culture has? If it's a patriarchal society, if it's a matriarchal society, if it's a society that believes the firstborn son should make a decision. And then is it the person who is paying the bills of the hospital who should be the next of kin? Because they do demand that I'm paying the millions for healthcare for my brother, for my sister, for my parent, and therefore I should be the next of kin. So when you get those challenges, then you go to the Hospital Ethics Committee and they'll be able to guide you sitting down. And then the concepts around respect for autonomy, the concepts of informed consent, privacy and confidentiality, they are key. And the question that comes in is, well, did we inform the patient before we got the consent? The biggest ethical issue is the information, the informed. Do we approach it in a way that there's full disclosure, there's full comprehension, and there's voluntariness for the patient to say, yes, I do agree to undergo this treatment, this investigation. And you realize that most of the litigations and the cases that we face are around these three: informed consent, privacy, confidentiality. You expose me to young people while they have not given a consent to be used as a teaching tool. Hospitals, which are both hospitals and teaching facilities, have to pay a lot of attention to informed consent. And if you have a challenge with informed consent, then the Hospital Ethics Committee is a resource that we should use. Privacy is, if I would say, is what the patient holds to themselves without being known to anybody else. So privacy to bodily integrity, privacy to what I know about my disease and my treatment, privacy to what I know I'm feeling. But once it leaves realm of the patient, then we are called upon to hold it into confidentiality. Sometimes confidentiality is breached knowingly, but most of the time is by the mistake and the errors that we do. However, breaching confidentiality simply because we never paid extra attention is not something that we can use to defend ourselves. So if informational integrity is lost, we breached confidentiality. If informational integrity is lost, we breached confidentiality. If relational confidentiality is breached, we've lost that. And we see so many people complaining about my information was known by my spouse, my information was known by my daughter, I did not want to know. My family came to know about my HIV status, which I did not want to know. Confidentiality does outlive the patient. And you get to a dilemma where you need to breach this confidentiality for the sake of the patient, but the patient clearly said that we shouldn't. We have patient, family, doctor disagreement variously because the patient wants to be treated this way, the doctor thinks the other way is good. The patient wants to go home. The family wants the patient to stay in the hospital. The patient wants to go back to the village. The family feel that the patient should stay in Nairobi because this is where best doctors are and all that. And because the family is paying the bills and the patient is dependent on the family, we all agree that the patient stay in Nairobi without knowing that we are doing harm. We are doing psychological harm to the patient. And they come and essentially complain and say, treat me, I go back to the village. I don't know who made us believe that big towns and Nairobi is the best place to stay. And patients actually do know where the best place of stay is. So, and the other disagreement is about the patient being in the hospital and they want to go home. The concept of LAMA, leave against medical advice, or discharge against medical advice, is something we really need to think about critically. It's not just a document. Medical advice, it is. It's not a prescription. The issue of paternalistic approaches that we know best for the patient to stay in the hospital become actually a question that we all need to answer. Is the care we are providing or the care we are proposing, can it be provided somewhere else? And the discussion and counseling for the patient and families is important. But if you get to this situation where you are not sure, the hospital ethics committee is there to guide you. At the beginning of life and pediatric care, we cannot emphasize the importance of ethical discourse. Sometimes we believe that it's those who are adults where ethics get applied, but pediatric is becoming very, very important. When a child is born in the country, it's called baby so and so of Joanne Tebet, Wajiko. There is no John, Joseph, or things like that. We've had challenges when they leave and then the maintenance of who is the next of kin to the child. And we have to discuss about that. And then the pediatric care become important because there are challenges about a child making a decision and not at the age of 18 and above. And here we call upon all of us to agree that the concept of assent by the pediatric population, especially those above 14 years, is very, very important. We don't just impose on to them. So we make the decision. Sometimes we do have issues about fights between parents or guardians about who make a decision for this pediatric population. So the issue of assent, the issue of decision-making is very, very important. And of course, at the beginning of life, there are difficulties, especially where surrogacy is being practiced. And there's a surrogate mother here, and when the child is born, not given to the parent because they feel that they carry the pregnancy for 9 months. We do face this every time. And one of the key issues we do face, especially with some religious outfits, is the religion. And I don't know whether we do appreciate the fact that anybody below the age of 18 has not yet professed any faith or religion. And we cannot impose the religion of the parents onto these people. They're still children. The delegated power to make a decision for the children by the parent is not absolute. So you get some religious affiliation, and sorry, I'll mention one, whereby you'll get a lot of challenges. For example, Jehovah's Witnesses believe that we should not transfuse. Yes, for those 18 and above who are in a capacity competent enough to say, don't transfuse me, yes, we agree, we would, and we don't transfuse. Even if the patient has a HB of 1, and they're able to make a decision, even if it leads to demise. When it comes to 17 and below, because they are not able to consent, and it is taken that they have not yet professed to Jehovah's Witness as their religious outfit, then we come in and say, oh, look here, we believe that this can save this child or this pediatric population, and we need to transfuse. And that's when you strongly recommended to call in the Hospital Ethics Committee. The extent of care for pediatric has become a very big ethical issue. We belong to a society and a context that we should not be losing pediatric population. They should not be dying. It's the old ones, 70 and above, who should be passing on, because it's a celebration of a life well lived. For those below 18, we ask ourselves, what did they do? They had not yet experienced. So you get a lot of ethical issues. And when it comes to that, please engage your hospital ethics committee. We do organ transplant. And organ transplant, any person going through organ transplant required to go through the hospital ethics committee. There is no option, especially the donor. Because the question here is, how altruistic is it that this person is donating their organ? Donating their organ. We are trained to do no harm, but we are doing harm by causing this patient pain, by making them get admitted, by doing incisions on them, by making them take pain medications. They are admitted, they leave their work. Do no harm is the key principle. So our main issue and why you need to engage the hospital ethics committee is about the donor. It's not about the recipient. How altruistic, how selfless is it? Without undue influence from the recipient, from the family, from the society, from their religion, and without being clouded by what the recipient has done to the donor. And of course, we do face a lot of issues around the policy and the administrative. Those are the cases that we handle. This is my summary of what we do. And if you see these, then you realize that most of the issues that we face fall under these summarized categories. So in summary, before we go to our discussion now, Q&A, the hospital ethics is actually a resource that should not be missing. And sometimes I feel that hospital ethics committee is required at all levels. And now the growth is there. There's commitment by the different players in the field. The Bioethics Society of Kenya is very key. NATCOM at the UNESCO is also important. But under the Ministry of Health, we also have the ministry very committed for establishment of hospital ethics committee in the institutions. So it does promote the rights of the patient. Once you promote rights of the patient and share decision-making, then you do notice that the distresses will come down. Promote fair policies and procedures, because when they look at policies and procedures away from the environment of those people who are developing the policies and procedures, they are able to pick ethical issues that might come later to dig in our heels and challenge us. Then it also promotes patient-centered care and outcomes. And patient-centered care is a key term that we use. But at what point do we have patient-centered care? Patient-centered care means that the patient has rights, but they also have obligations. And those taking care of them have also rights, but they also have duties to undertake. And what are the outcomes that you're looking for? About predictions, about outcomes. And of course, ethics education to promote ethical environment for healthcare delivery. Based on the context, based on the resources, based on the socio-cultural environment and the patient belief system. Please remember, we don't say we need to be rich for us to have a hospital ethics committee. We don't mean and we don't say that we have to have 200-bed hospital, 1,000-bed hospital to have a hospital ethics committee. Even an institution that takes care of outpatient people walk in, walk out require a committee. And this is where we need to head to, because outpatient care also have its own ethical issues. Communication, who brings in the patient? How does the patient walk in and walk out? How do we detail confidentiality? Of course, it also does promote it is ethical and moral distress on the healthcare providers. And with this, it releases them to continue taking care of other patients. And at the end of it all, it's an advisory committee that is available 24/7, 52 out of 52, day in, day out. Once you set it up, it's never unavailable. So please, 24/7, get to your hospital ethics committee. And I want to stop at that point so that now we can have some discussions. Thank you so much.
Thank you so much, Prof, for such an elaborate presentation, detailed, and we can type our questions, which will be responded to by Prof, I believe, in the next few minutes we have before we end the webinar. And I see a question from Leonardo Runga that says, thanks for the presentation. Does the clinician need to consult the healthcare ethics committee before filing the discharge against medical advice form?
Thank you. Thank you for that question. I would strongly advise that where you have a hospital ethics committee, please call them, inform them, even as we proceed to fill in the leave against medical advice. And please document that, so that if anything happens to this patient, it will be a full 360-degree care from the health institution and healthcare facility. We have had experience whereby a LAMA was signed for a pediatric child, and something happened to the child when they left the institution. But fortunately, the person who called in had discussed with members of the hospital ethics committee. So they went in and said, oh, we were mistreated, we were not fully informed. But looking back in the notes, the clinician had talked to them. And now a independent committee called Hospital Ethics Committee had also come in and made its own observation, recorded the same. So of course, the court said now this was fully informed because the institution gave you all the resources, all the options, and they actually did engage someone who is independent and not a member of your treating team.
Thank you, Prof. Another one from Becky Buretti. What can we do if a mother brings a sick child to the hospital who requires admission, but then the mother declines admission either on the basis of finance or saying she left other young babies at home?
Okay, a very tricky one. And that's where you're talking about context. So the mother came to the hospital, brought in a child, and they cannot pay the bill. So meaning at that situation, given the disease, this child can be called an indigent, meaning they cannot be able to pay. The first question you ask yourself is it an emergency? When it comes to emergency, the treatment has to be provided. What is the well-being of the patient? What is the well-being of this child? Continuing to stay with the child is important. If it is important, then it details that the hospital and the institution has to essentially come in and say, oh, this is the way to proceed. They left other children at home when they were bringing this child. What are the other options we have? And in this case, it's very important that we engage the social worker. The social worker comes in very, very important to understand what is the social background, social setting, even when they say they cannot be able to take care of the child. And then the institution say, if that is not possible, and we can, for example, an emergency, the child has to be in hospital and admitted, it's always very important for us to engage our leadership to say, this child needs to stay. Or sometimes you feel that the child can be transferred to another institution, either by the parent's choice or because of the other dynamics that detail this. If they are not able to pay and it is not an emergency, the institution and the hospital has the power to discuss on how they can be taken care of in another institution once stabilized. And this becomes a very big challenge. When a patient gets into that gate of the institution, they are sick. They cannot just be turned back because they don't have finances. One, they have to be caught. Two, they have to be examined. Three, any investigation that is very critical, emergency. Four, if they need stabilization, they need to be stabilized before they can even leave.
Thank you, Prof. Another one here from Jasper. Cases of mothers who choose not to breastfeed their newborn babies. Does this need hospital ethics committee intervention?
Wow. Cases of mothers who refuse to breastfeed. I think this one require not to go to hospital ethics committee direct, because if the child is being fed in other modalities which are ethical and medically recognized, sometimes it becomes critical to consider those reasons why they are not breastfeeding. Breastfeeding has got social, cultural, and sometimes within the contemporary societies, it also has some other communal meaning. I believe in such a case, as long as the child is being fed, it's good to discuss with the mother and also to understand why they are not breastfeeding. Where are they coming from? But the assessment comes in to the clinician who sees the patient, or the healthcare provider who sees the patient, to make sure that the child is not malnourished because the mother is not feeding them, because that now becomes a case of child neglect. And sometimes the law can call it child abuse if you're not feeding them. So that's the way I would approach it. Please remember, for the discussion, for our discussion now and moving on, a healthcare provider is anybody who comes into contact with the patient. It's not only the clinicians. So that's how I would look at it. And when it comes to the child who is not being breastfed. Thank you.
Thank you, Prof. Rosa asks how to handle a mother who declines CS delivery when her baby is in dire trouble. Who advocates for the unborn baby, and how do we, in emergency situations, approach this?
Okay. I think that's a very important question. So who is the patient in this case? The mother is the patient. However, it does extend beyond the mother, because we have another person. An unborn baby is also someone who requires respect for personhood, and their well-being and welfare must be considered. So when the mother meets the criteria, and we believe that the baby might be harmed by not doing a cesarean section, it's very important to engage the hospital ethics committee if they are available, but also to engage other obstetrician gynecologists for their opinion, for discussion, as we discuss with this mother, and understand what is causing the mother not to agree to a cesarean section. It could be just be finances. It could just be some misconceptions about cesarean section once it's done and all that. And sometimes they do believe we've had cases where they believe if a cesarean section is done, then these people will also remove my ovaries and I won't be able to give birth again. Understanding where they are coming from and reassuring them is very, very important so that we can advise the best way forward.
Thank you. Elizabeth asks if a healthcare worker decides to stop treating a patient because they are in danger, patient being abusive, etc., and would want to transfer care to another healthcare worker, does the committee need to be involved?
An important question. A healthcare worker or a healthcare provider to stop treating a patient. Now, when it comes to anything affecting the patient, place of care, level of care, point of care, and source of care, then the committee is good to engage them and to involve them. As we said, the healthcare provider has got duties, but these are balanced against their rights. So a healthcare provider can say, because the patient is abusive, I cannot continue taking care of this person. And then ethically, they are detailed to refer this patient or transfer this patient care to another equally qualified healthcare provider or another institution that can provide the same level of care. But it's become very important to engage the Hospital Ethics Committee because it's a third party, it's another ear that is being engaged in such discussions. But I agree that these are things which are coming in and need to be considered. And the Hospital Ethics Committee now, if you talk to the quality department in the various institutions, are becoming very important to advise on how to approach such issues, because we are getting very tricky patients and family members. They'll say that we were chased from the institution, we were neglected. But also the courts are taking it to be very important to engage the institution entirely, document what you've done, and the Hospital Ethics Committee become a critical resource.
Thank you, Prof. Anonymous, which areas of research gaps would you recommend in regards to Healthcare Ethics Committee in Kenya?
Oh, research gaps. I believe is about what constitutes a Hospital Ethics Committee membership and composition based on our different context. And secondly, the engagement of hospital ethics committees, the development of the same, and the issues that they do advise and deal with. Is there a need for hospital ethics committees in Kenya, for example? Because the need and the establishment of hospital ethics committee in Kenya is not because a research was done to show that there's a gap for the need. It's only that for there to be quality care, we feel that hospital ethics committee is important, and where they have existed for several years, we've seen that the quality of care has improved. So essentially, you can pick any subject. For example, look at informed consent. What are the role of hospital ethics committee in the quality of informed consent in the country? What the role of hospital ethics committee in the formulation of policies, guidelines, and protocols that we have within the country based on our context? So there are various topics and many ways of looking at the gaps.
Well put, Prof. And we have Bernard, in pediatrics, which is superior, the Children Act of Kenya or the parent?
I won't say which is superior. I'll look at the context. Because the context itself informs you about ethics. It informs you about the social context. It informs you about the belief system of the parent. And then it also informs you of the needs and the requirement of the child. So remember, ethics does inform the law. And the law is both either prescriptive or proscriptive, but ethics does depend on what are the issues that we are dealing with. So you need to listen to the parent, but you also need to consider the Children Act. And sometimes you have to be flexible enough to accommodate where the parent is coming from, despite the guidance by the Children Act, as long as the welfare of the child is taken care of.
Okay. Then what about ethical issues of abandoned children and care decisions?
Okay. I think this is where the children's social system comes in. And they should be able to be engaged. And once they are engaged, then taking care of them just like any other patient, they require the full cascade of care. The ethical issue that we do face is when a child who is abandoned comes to us and they don't have a surrogate or a guardian who make the decision for them, who should decide what treatment should be given, who should be able to converse and communicate with the healthcare providers. That becomes an issue. And therefore, most of the time, if they are brought in or they come to us and there's no identified person or the person who brought them is not related to them, then what we do in such a case, consult from the word go the Hospital Ethics Committee and your leadership. And the Hospital Ethics Committee will be able to detail and advise that two equal consultants can be the people to make a decision for this child, even as the institution itself goes to court to seek for guidance on how to proceed with the child. Remember, care has to be provided like any other patient, meaning if they come to your institution and they are abandoned, you have to seek what you need to do with them. And that's why we have to have a very strong social welfare network within the institution.
Okay, we combine this. What you do in a situation where a patient is admitted in unconscious state and the next of kin advised not to be treated or resuscitated. And the other one is what do you do if a mother insists on her child being discharged even while the child is still unwell?
Okay, these two are clearly related because it comes into the issue of the making decision by the next of kin, by the parent, by the guardian. Is it absolute? Even the person who holds medical power of attorney, the decision made should be geared towards the welfare and the well-being and the benefit of the patient. So sometimes we feel that what decision is being made against a recommended treatment or a demand that is being made for a treatment that is not recommended are not applicable in these cases, whether it's a child or an adult who is unconscious or who cannot make a decision for themselves. And these two cases now, 100% reason to call in the Hospital Ethics Committee because they do approach it into different ways. When you have a Hospital Ethics Committee, it looks at, in the case, from four sides. What are the medical indications for the care? What are the contextual factors? And in case of this patient who is unconscious, but they are competent and capacity to make a decision before, did they have any prevalences that they had? So the approach by Hospital Ethics Committee looks at the case from different angles, not only the clinical angle. And in these two cases, then please improve them. When a mother insists on her child being discharged, let's understand why they want their children to be discharged and they are not unwell. Is it because they fear that the home will break up? Is it because they fear that other children will be taken care of? Is it because they don't have the resources to continue the care in the hospital? Is it because there is a family social issue? And once you dig deeper, you realize that there's something informing a mother to say, do not continue the treatment and let us go home. And once we understand what it is, then we are able to engage stakeholders or our partners who can deal with the issue at stake.
Thank you, Prof. As we wind down on this, there is one from patient context is important. How does the healthcare committee go about involving patients in cases brought to them?
Oh, that's a very great question. Now, we do recommend that we are consulted by the primary team or primary physician. They need to inform the patient that we are bringing in a hospital entity which is independent because of this and this and this. Just like a physician, primary physician, will detail the patient and inform them that I'm calling this other specialty. This should also go in when you're dealing with a patient with the hospital ethics committee. They need to get informed. When they are not informed, and the hospital ethics committee will essentially, in their process and procedures, require to discuss with the patient, then they'll introduce the fact that they were called in. So communicating with the patient about engagement of the hospital ethics committee ideally should come from the primary treating doctor or the person who consulted the hospital ethics committee. If not, and the hospital ethics committee will talk to the patient, then it will be them to introduce. So the patient, it's very important that the patient should know.
Thank you, Prof. A lot of now.
Hello.
Hello.
I think we lost John.
I think we've lost Reverend, but we were coming to an end. So there's a comment here that this is a wonderful presentation, that ethical dilemmas aren't as black as white most of the time, especially when we have issues of pregnancy and babies. But there's a lot of new research advocating for patients' rights. So we should be human and incorporate empathy with our patients while maintaining professionalism. And a listener from Nigeria, thank you for joining us. Joseph Fadare says that in Nigeria, hospital ethics committees are rare. They only have research ethics committees, but this presentation has challenged him to work on establishing hospital ethics committees.
Oh,
Yes.
great. And
yes.
If you see this comment about the context, every case has got its own specific, special nuances and particularities. And as it is said, ethical issues and approach is not black or white. It's actually more gray in most cases. So I believe that looking at them based on those contextual factors is very, very important. And it needs to be the specific issues. It's not copy and paste, because you have a patient, you can have a patient with an ethical dilemma or an ethical issue, similar diagnosis, similar age, similar whatever. But when it comes to one specific element, then that delineates them from the other patient. So it's true. Thank you, Esther.
So we would like to come to an end. Thank you so much. I would like to first thank our speaker, Professor Weru, for sharing his time this afternoon to give us insights on this wonderful committees. There have been lots of questions in the chat, and some of them we have responded to them. It was not possible to respond to all of them here. I would next like to thank Reverend John Panyi Maina for being our moderator for today. And I would like to thank the participants. 530 of you have stayed through the presentation. Thank you so much for joining us this afternoon. Have a great afternoon as we continue to engage in discussions about ethical issues, and we'll be bringing you the next webinar in the next quarter as we start our financial year. Thank you so much. And remember that ethics committees are available 24/7. So when in doubt, please reach out. In Kenyatta National Hospital, our secretariat is the Patient Affairs Unit, and they direct all the matters to the committee, and we are able to address them. Thank you so much. Feel free to log out at your own volition.